Why don't we start? I'll call the meeting to order. Since Jan is here, she probably doesn't know everybody, so we can start with introductions. I'm Mary Hutchins, the chair. Nicole Zhu, the vice chair.
Sheila McHenry, member.
Hello, Jake Parker Carver, Peer Addiction Recovery and Substance Use Subcommittee Chair and member.
Jackie Wunderlich, member.
1 year Friedlander, Deputy Commissioner of Community Services.
And those of you online, can you?
Sally, you're muted, Sally.
Sally McConnell, Janae, member.
James Beaumont, the co-chair of the Developmental Disability Subcommittee.
Larry Roberts, I'm the chair of the Mental Health Subcommittee and a member of the Community Services Board. And for some reason, my camera isn't working, so I'll just make a noise when I want to be recognized.
Thanks, we recognize your voice. Good. And Karan.
Corinne Palazzo, I'm the LGU Administrative Assistant.
I'm Janet Thibodeau, I'm the Quality Assurance and Improvement Coordinator.
Thomas Kelly, Chief Ithaca PD.
Jessica Connor, member of the board and mental health subcommittee.
Okay, thank you. Any additions or deletions to the agenda? Anything? All right, and so the minutes of February, we could have a motion to approve those. Sheila, and that's in a second from.
Can we see the whole committee, basically? Thank you.
It works automatically and focuses and unfocuses.
Great. Are there any corrections or additions to the minutes?
I have one correction, actually wasn't correct. It says
You don't want to be misrepresented.
I thought the copies to the minutes are really great.
meeting.
Stressful. Yeah, I think the minutes are great, and the minutes of late have been very, very informative.
Great. I was here in person, not on Zoom.
Nobody was on Zoom.
We did have Zoom, but
I tried to help with Zoom, but
I wasn't. That was a crazy day. Just you said you were on Zoom? I was not on Zoom. Okay, did I have you on Zoom? Zoom, mine doesn't. No, you couldn't get Zoom to work.
Oh, Mary and I tried to be on Zoom.
Yeah, you did.
It was kind that you allowed us.
We saw you and heard you, but.
So with those corrections, all in favor of accepting the minutes? Minutes, great. All right, any privilege of the floor?
Jessica, two things. One, our trans youth are increasingly at risk of losing access to their gender affirming hormones and puberty blockers. In our region, Bassett Health, which is about 2 hours east of here, has discontinued all of their gender affirming hormones for youth, as has NYU in the city. Thus far, our main go-tos of Upstate and URMC are continuing to provide access to gender affirming hormones and puberty blockers, but that is at substantial risk, depending on what happens with some bills coming out of the federal government. So we're doing some scrambling to try and figure out how to continue to provide access to care for our trans population, which is a pretty large population in our county compared to other areas throughout the country. However, as a county, we continue to not have any providers who provide gender affirming hormones or puberty blockers to youth. And so that is something to just have on folks' radar. The second comment is that anecdotally, youth mental health locally is very high acuity right now. We've had more youth in and out of the emergency department and regional hospitals more so than I've ever seen in the past 7 years. The acuity level of folks with suicidal ideation and eating disorders is very significant and acute right now.
Can you explain, do you know the reasons why it's become so prevalent of late?
Only conjecture. I think that it being cold for a substantially large period of time and people being stuck indoors, along with the chaos of the general state of our country, is my only read, along with the rampant use of weight loss injectable medications, which is having a detrimental impact on, as a society, people using it more is leading more youth to be restrictive in their eating, is my conjecture, not based off of data. Just wanted to put that on folks' radar.
Any other comments? Jacob, I don't know if you wanted to mention how your event went.
Oh, it was great.
Okay.
On February 12th, we had the first screening in the Recovery and Community series at Cornell Cinema. We watched The Outrun and did a panel discussion after. It was well attended. We had an engaged audience for the panel after, and it was a good time. The next screening will be a documentary called Crazy Water, happening on February 12th, 6 o'clock, Cornell Cinema. Crazy Water looks at cycles of intergenerational trauma and addiction in Indigenous communities. And afterwards, I'll be facilitating a panel discussion with a group of Indigenous folks who themselves are in recovery. And I'm very excited about that. Thank you for asking.
Yeah, so that's March 12th.
That is March 12th, yes. Cornell Cinema, 6 o'clock, free popcorn.
Great, thank you. Very good. Any other comments? Great, and I have no board correspondence. So I guess we could move on to James' report. Thank you, James, for coming and filling us in on what's been happening on the subcommittee.
Of course. Can you hear me all right?
Yes.
Okay. So unfortunately, Jeff Bowles, my co-chair, is not able to be with me today, but we talked ahead of time and kind of discussed what we would be reporting on. I'd say one of the big things for 2026 is Jeff and I have decided that we're wanted to try to create more structured talking topics for each meeting. So instead of scrambling each month to figure out what we're discussing, we actually set forth a set of topics for the entire year, and then we're reaching out to people that we've touched base with in the past to be able to try to have them come and present and be able to discuss those things. So we've already done things like our developmental disability day services like Day Hab and Community Hab, respite services, those type of things have already happened, but we have coming up transition services, inclusivity and youth services such as camps. We're going to have the ADA come in and do a presentation about the requirements for camps to follow the Americans with Disabilities Act, housing, and employment services, and also aging, which Jeff is talking a lot about, that our folks with developmental disabilities are getting better care, people are living longer, but there's a whole lot of then other issues that come along with people with developmental disability living longer and longer. So we're excited about that. It's created more structure. We're reaching out to people ahead of time and not, a couple of weeks. So we feel like that's getting more thorough, thought out topics to discuss. So we're excited for that. And we're also working with Shannon Elvord at the county to try to work on highlighting things like awareness months for developmental disabilities. March is actually Developmental Disability Awareness Month. We're going to work on highlighting the Americans with Disabilities Act, which I think is hitting 35 years. I think July, if I remember correctly, is Autism Awareness Month. So trying to work on just educating the community more about those things, I think will be helpful. We are also in the midst of planning our fourth annual resource fair. So I just got the insurance from that. Thank you, Harmony. So we're going to be booking, hopefully, the Boynton Middle School. And that's an in-person event where we try to have all of the providers in Tompkins County in one room and we try to invite people come in to learn about all of the service options. We oftentimes talk to people who are just saying like, I'm not aware, like my care manager doesn't know. My care manager is based out of Syracuse, so they don't know what the options are. So we try to have this in-person event to be able to people come in, learn about what options there are, and then we take the information that everybody gave out at that event, we compile it, and then try to have a resource list. So if you weren't able to go to the event, we're able to give you the resource list so you can hopefully find out about options available to people if you're not able to go to that one-day event. And we're also working on, Jeff's been on the DD subcommittee since 1999, and we are very close to, for the first time in 27 years, having an actual roadmap for people with developmental disabilities. One of the things that we hear oftentimes from family members is it's just such a confusing system to try to navigate. There are so many hoops to jump through, and a lot of times people just get bogged down and don't continue with the system. So with the cooperation of Racker Center and a couple of other people, we're trying to create a roadmap where we could hand it, a pamphlet or a packet to somebody and say, step one is diagnosis. You cannot go further into the system until you get a diagnosis. And I talked to Jessica Connor about that and being able to have it be Tompkins County specific. We really want these resources to be people and agencies that people can actually contact in the local area. So we're very close to being able to have something to hand out to people, which I think will help a lot with access, to really give some concrete information to people and improve things in that regard. I'll also just say that I was fortunate enough to go to Legislative Day in Albany again for the fourth year in a row. It's always nice to hear what's going on in Albany, what's happening with the budget, but unfortunately, a very bleak outlook. Most people just stating OPWDD's budget come 2027 is not looking very good with the cuts that are coming. So that at least is helpful for us to start bracing for, the year to come. We are hopeful to get I think they're calling it a targeted inflationary increase at the state level now, but we're hopeful to try to get a 2.7% increase. I like Legislative Day because they have concrete information for people to be able to access when trying to get people to advocate for us. So I had sent it out through the DD subcommittee email chain if anybody's interested, but there's a very specific step by step of how you can advocate for the OPWDD budget and try to increase this year a increase for our reimbursement rates. So that is my spiel. Any questions? I try not to be too negative, but I know sometimes it's hard to stay positive with things.
I had a question. The last time I heard discussion about a roadmap or a resource for people who are looking for developmental disability services, and this was several years ago, that the county worked with 211 to create a database or a centralized index within their organization that if somebody called for information about developmental disability services, the operator or the person answering the phone could find it and could understand the information that they were providing. I think, if I remember, and again, this was several years ago, I think they wanted to get away from the idea of a paper roadmap and have it located online and with people who would be able to provide more information than a paper resource would. So I would advise that working again with 211 Tompkins might be a good first step.
Unfortunately, we have been talking to them the last couple of years, and they said they do not have the funding anymore for operating that kind of resource. But we have talked to Harmony that whatever form that we come up with, we're able to put it on the county website in the Developmental Disability Subcommittee page. Correct, Harmony? Yep. So we're going to have a physical copy because a lot of times people can't access electronic versions of things, but we're also going to have the electronic version of things that people can access.
Okay. I'm glad you talked to 211. I'm disappointed that they don't feel they have the resources. I know they probably have developmental disability stuff listed in their database. So
Yes.
you may just want to remind them of that and to um but I think putting it on the county website once it's finished is a good thing to do.
Yes. And yeah, because we had been talking to them because my understanding was they do have a resource list, but we were looking to create something that's a little more in depth about what are the steps to go through the OPWDD eligibility process, which
Right.
is a little more extensive. So we're looking to have something that has more of a play-by-play of that. Same thing. There are apparently some organizations throughout New York State that will actually help you fill out your Medicaid application with you. So we're looking to like have those step-by-step processes and resources as well. So I think it was also a little more encompassing than what 211 had been working on, was just if you want residential services, here's a link for four agencies kind of thing. But thank you for that. I appreciate that info, Larry, because yeah, we had been trying to work with that.
One thing I'll
Maybe one of the one of the providers from the DD world locally would be willing to house something.
And that's Jeff and I's hope, is that we want it to be attached to the DD subcommittee and it lives past us, and that it stays with the DD subcommittee, that whoever takes over after us, it's going to be their responsibility to keep it updated. It's going to be their responsibility to, make sure that it's maintained on the website and refresh things and everything like that. So that's our hope, is that it kind of gets ingrained in this subcommittee.
Nicole.
Yeah, I was gonna add, as a person at Human Services Coalition, which those who don't know houses 211, James, what I might suggest, though, I don't know if you had this conversation, I'm looking right now at our resource directory, and we have like different categories, and that is not like developmental disability resources is not a category, and I know that's something you can talk to Nicole Roston about. If you're able to like kind of group all the resources so it's a little bit more easier to accessible.
Sounds good. We'll do.
Nicole, do you know if conversations have gone any further between 211 Rural Health Institute, Youth Services Department, and the Monroe 211 folks about utilizing the infrastructure that Rochester has built up around a more interactive?
I know there was initial conversations. I don't know if anything happened past the initial conversation about that, but I know they did have an initial meeting. You were there. Okay, I was like, I know I was there. I'm not sure if they met since then. I know they haven't not been included.
Any other questions?
Jacob?
Yes.
Hey, James. So I know you had said that ideally you'd like to see all the stuff on the roadmap be services or providers that are acting locally. Currently, are there glaring omissions? Are there stops that should be on the roadmap that, nope, you can't get this in Tompkins?
Not per se. I mean, the thing that we're talking the most about is the decreasing of those options. Again, after talking to Harmony, Jeff and I had reached out to Tompkins Weekly. We were just interviewed by them to talk about the reduction in housing. We're at about 80 less beds residentially in Tompkins County than we were pre-COVID. So I don't think there's a service that isn't available. It's just the biggest thing being we're getting fewer and fewer options. One of the residential programs in Tompkins County just completely decided to stop providing services. So they're not even, it's not like they have less beds. They're just not a provider anymore. And that fewer options, we're looking at longer wait lists, that a lot of people want the service. The service is available, but it's taking longer and longer to try to have an opening occur in the program.
A caveat to that is that we don't have anyone in Tompkins County who does autism evaluations that accepts insurances.
Okay. And yes, and to clarify, when I talk, I'm so much in the provider world, I'm talking Dayhab, residential ComHab. That's why I'm excited to talk to people like Jessica and the roadmap, because I have a complete lack of knowledge of getting diagnosis, going through eligibility, those kind of things. So that's what I'm excited about, is have all of the people who have more detailed information in those pockets and kind of smush it all together and have it be a kind of a one-stop shop. Because like Jeff and I, when people ask us about diagnosis eligibility, we're just completely, I'm the last step in the process. I don't do any of those steps. I'm just, when you've gone through all of those steps, then I'm able to provide a service. So, but I'll make sure that that's in the roadmap as well. Because that's where I find parents struggle. They're just like, and now I got to travel to go get a diagnosis, like one more thing, one more barrier, one more roadblock. So, those are the things that we want to make sure we highlight.
Which, as an update, the nearest place that accepts insurances is Syracuse, and they're currently working on their 2023 referrals. So it's about a 3-year wait if you go to Syracuse.
The nearest place that accepts any insurance.
Yeah.
Well, Rochester has a shorter wait list.
Right. If you go 2 hours out, then Rochester is trying to get people in 9 months.
Yeah, but the quality of the evaluation that they're doing now compared to pre-COVID is very minimal, so it's actually not that helpful.
And they will only evaluate people after they have gone through an educational evaluation by the school district.
Well,
as well.
Is this conversation just about children or adults? Yeah,
both. The kids aren't doing great.
It's important information. Visuals help me understand systems, and the idea that like there's this huge bottleneck before you even get to drive around on the map is wild to me.
Yeah.
It's a good way to put it.
Yeah, the map doesn't do me any good unless I can get to it.
Any last questions? James, thank you so much for coming and for all you're doing.
Appreciate it. Thank you very much. Have a good evening, everybody.
Thank Jeff too.
Yes, we'll do. For sure. Thank you. Bye.
Thanks, James.
Thank you.
All right. So we'll move on to Jana's report. Thank you for coming, Jana.
Yeah.
Those of you who remember, we do this annually and get a report on the incidents that have been identified.
So just a quick background, I wasn't sure how many new faces there were going to be, so I tried to make it a little bit of review and also some interesting new information. But the Incident Review Committee is, because we're regulated by OMH, we are mandated to have an Incident Review Committee where we look at whatever qualifies as a reportable incident for outpatient services. So in general, those include client deaths for any reason, suicide attempts, fatal overdoses, and crime in the community are the 4 buckets that we see the most of. And then the committee is tasked with reviewing what happened in the situation and looking at our processes and trying to come up with ways to mitigate future risk for our clients. So that's like an overview of the purpose of the committee. So the membership, this is very small. Can we put it in present mode? In present mode?
Slideshow.
Where? Go up.
Slideshows. Right, the slideshow.
Yeah. From the beginning.
From the beginning over to the left.
Just hit the button, it should switch it.
The arrow.
There you go. So I am the co-chair and we have a new clinic director who's my other co-chair, Hillary Riley. And our composition is generally the same from the previous year. So it includes different levels of leadership and clinician representation, including Harmony and our medical director, our clinic director, all three of the senior supervisors for the clinic, the pros director, and we added a peer specialist this year. So there's a requirement from OMH that you have, what is it? I forget the term, but it's basically you have somebody who represents the community you're serving on your committee, but that's a little bit sticky because of HIPAA compliance. And so we found that a peer specialist is a good way to have somebody who's already done all the HIPAA training and who it's ethical if they have access to that information, but they can also represent the clients that were being reviewed. So in 2025, we had an unprecedented number of cases. We reviewed 64 reportable incidents for both pros and the clinic. So in comparison to 2024 is on the left, 2025 is on the right. That we had 18 total deaths, 14 of which were natural causes. 2 were fatal overdoses, 1 was a car crash, and 1 was a homicide. We had 33 suicide attempts, including 22 non-fatal overdoses and 13 other types of incidents, all of which were categorized as crime in the community. So I can't report to this committee on the very specific cases. So I try to categorize the types of improvements that the committee discussed, and then talk about how collectively as an organization we've worked on these categories. So addressing co-occurring substance use disorders, improving coordination of care, both internally and externally. If I had to say one area that we've really done a lot of work this year, there's been quite a bit of emphasis on that, both for external and internal coordination. Person-centered services. So that bucket includes like risk, like identifying high-risk clients, documentation, compliance, and then also tailoring like caseloads and episodes of care to be more client-centered. And we've enhanced school-based therapy services. So that speaks, we had quite a few more youth cases this year, and I would say the acuity of them was more severe.
That's what I was gonna ask. Are you able to break down within those numbers, youth versus adults?
I can, but I didn't for today.
Okay.
But I'm happy to send that to you.
Okay, thank you.
Yeah. Staff retention and development, and then there's policies and procedures. We have a committee. There are some that are often relevant to the incident review committee that if we change a process, we want to reflect that in our policy. So I just sort of catalog that for this presentation. So I also wanted to just overview different levels of goals in the organization. So these are actually 2026 goals that Jenny just came up with for all of Whole Health. These are not all of them. These are the ones that I pulled out that are most relevant to the corrective actions for the incident review committee. So one of the internal priorities is to assess mental health services to identify needed changes in scope, focus, and workforce practices, using staff and client input to guide activities that strengthen workforce resilience, advance equitable, person-centered integrated substance use and mental health care for those who need it in Tompkins County. So I think the emphasis I picked that one out, both before like sort of realigning services and then also the integrated care for substance use and mental health. One of the external priorities was to deepen collaboration with sibling agencies by establishing or strengthening at least 3 partnerships that align with shared public or mental health priorities, including regular bi-directional communication and joint problem solving, and intentionally engage leaders and staff representing diverse roles, disciplines, and communities. So I picked this one because a lot of what we've emphasized is offsite services and collaboration with different organizations in our community. And then equity, there were 2, they're both really good. I had a hard time choosing. But expanding recruitment pathways and building a stronger workforce pipeline so that new hires more closely reflect the racial, ethnic, and linguistic diversity of the community by deepening partnerships with educational institutions and community organizations and using inclusive, bias-aware hiring processes. So we serve a diversity of clients, and we are striving to reflect that in the staff that serve them.
What kind of partnerships are you looking at? You mentioned at least three. I mean, have you selected these partners already or?
So that's for all of whole health, but I would say that for the mental health side of things, we are offering offsite services with some of Lakeview at their SRO, at West End Heights, and also at Southside Community Center. I think we're about to collaborate with GIAC and the Village of Ithaca. So those are like some of we can offer some offsite services consistently at different locations.
I thought Village of Ithaca had lost their on-site therapist.
Tyra's still.
I know, but I don't think she's functioning at the Village of Ithaca.
Yeah, I think that what we've tried is to pilot in different locations, so it's sort of fluid and based on youth need.
Yeah.
So if there's a youth that attends there regularly, and that would be a good fit for them. We're also looking at expanding our school-based satellites. And we're in some other locations that I cannot now.
No, I had heard about.
Some of which have been so successful, we're considering making into a satellite. So it's really like, there's some services that are sort of looking like, oh, this is a very good location. We always get a lot of community members who are interested in it. So they're more like a pop-up right now, and we're trying to figure out how to build. Yeah. There's been a lot of things also like with the shelter population.
These ones are more specific to the mental health services side. These are sort of established, and we are continually targeting improvement in these areas. So integrated care, so mental health and substance use, trauma-informed care, diversity, equity, inclusion, and belonging, suicide prevention, and client engagement / customer service. And then these ones are the clinicals. So the IRC covers both pros and the clinic. I think 90% of the incidents are clinic clients. So these are actually 2026 priorities for Hillary and the clinic, to continue to expanding services to the community, to offer groups in the community, including a step down group. So for people who are sort of like disengaging with individual therapy, that they have a way to do that intentionally. Medication management pathway, which I'll talk a bit more about. Discharging clients before they stop showing up. So there's sort of a sweet spot around 7 months where people feel done with therapy, but don't maybe feel comfortable saying that. So helping them to identify that they've successfully completed an episode of care and they're welcome to come back if they need another one. The working on our work environment, so culture of feedback and self-care that is ingrained in our culture, and case management for our clients. So that's like big to small goals that are interconnected.
It should be noted, the reason most of these are related to the clinic is the clinic has about 2,000 clients and pros has around under 100.
I need to see the arrows on the keyboard.
Oh.
There you go. Yeah. So one of the first buckets of corrective action was addressing substance use and opioid use disorder. So we participate with OMH has quality improvement collaboratives, one of which was focused on opioid use disorders and overdose prevention. So they kind of set up a framework for us to focus improvement efforts for substance use related care. So it starts with screening and diagnosis. So identifying the people that have a substance use disorder, and then offering naloxone or Narcan kits, and then also offering medication assisted treatment. So those are sort of the three focus areas that OMH was looking at. So as far as identifying and diagnosing substance use, currently about a little more than 75% of our clients have had a substance use assessment in their chart, which is, it would be great if it was 100%, but that's a huge improvement from when I started. And then of those people that have been screened, and assessed, about 50% of them have identified a substance use disorder, which is probably an underrepresentation, partially because of underreporting. And then this is a breakdown of diagnosis, like ICD-10 codes.
Just to clarify quick, so 75% of clinic patients have been assessed.
Yes,
And of those that have been assessed, 50% of those have been found to have a substance use disorder?
yes.
Whoa, okay.
And that we don't do assessments for people under 12 unless clinically indicated.
Can I ask a quick question about?
Yeah.
Is there a hard stop in the electronic medical record or alert that pops up if the substance use screen has not been completed?
Our electronic health record is a little bit antiquated. Jenny has really made it a wonderful goal to try to improve that situation. What we did do is we created a new comprehensive assessment and we embedded the substance use screeners into that. And then if it scores above like whatever the evidence-based criteria is, then the clinician is indicated to go to the substance use assessment. So they can't sign the comprehensive assessment unless they've done those.
That's great.
Those screeners, and we have different ones for youth and then for adults.
Wonderful.
I have a question about the chemicals used by clients. It says nicotine, that in their charts, only 7 people have been identified as using nicotine. That so seems to me that we should
Not likely.
update people's charts, because I'm sure more than 7 people in the programs smoke, unless suddenly all of our efforts to reduce smoking have succeeded wildly beyond our expectations.
Yeah, I agree with you. I'm going to guess that the people that have a nicotine use disorder in their chart are the people that we are providing medication assisted treatment for. So it has to be in their chart in order to bill for the service. I know that PROS has done a lot to train their staff in different evidence-based interventions for tobacco use. So there is a gap, and I think that's partly why OMH emphasized the identifying and diagnosing as like the first step in the corrective actions. Is part of it is not just discussing it with the client, but also documenting it in the chart. And there can be sometimes a significant gap between those two steps.
Are these like discrete numbers? I mean, there's no overlap. For example, someone could have an alcohol issue who also, smokes.
Yeah.
I mean, did you kind of parse those out or?
It's
there
ICD-10
duplication
code and people can have multiple ICD-10 codes.
Yeah.
So if I drink and I smoke, then both of those would be in my chart and they would count as a count of 1.
So this is a duplicate number.
Well, it's for clients. Yes. Like it's not it's not just 1-to-1 diagnosis to client.
We also shouldn't assume that everybody who lists that they use alcohol or cannabis or smoke are necessarily at an abuse level or a misuse level.
Different diagnoses. So the diagnosis, and Harmony, you could probably fill in the gaps on this one, but there are different like moderate, severe. So if it is a disorder, there's like different diagnoses based.
Yeah,
They're not.
I'm reading this as these are the numbers that have a disorder,
Right.
not who have ever used in their life.
Right.
These are not people
Okay.
who have used. This is people who have been diagnosed with a disorder.
Okay.
Which is covered a bit in the screeners. So the screeners will say, if you drink casually once a month, you're not going to screen as needing an assessment or as having an alcohol use disorder.
But it's sort of a national statistic that in outpatient mental health clinics, about half of the people you're serving are going to have a co-occurring substance use disorder. So that number is about right. Even though nobody's smoking in our clinic.
And
interesting to see because some of it is self-medication. If they're taking their meds or if they're choosing a different substance to kind of manage what they're dealing with.
Absolutely. So this is our Narcan distribution slide. So that's the second step in the OMH substance use pathway. So in 2019, we became an opioid overdose prevention program, which is a certification that allows us to directly distribute Narcan kits from the state, which was renewed in 2025. So we distribute them with xylazine and fentanyl test strips, as well as an informational brochure. And we updated our policy. So we've grown a lot in this area. We used to have they were only in the nursing medical room and you had to sign them out. Now we offer them on every floor. We offer them to the public. Clinicians have access to them. We provide them to all clients who want them and offer them to clients. And per OMH, offer them also to clients maybe who don't use themselves, but who go to parties or have friends who use. So I think that has changed a lot in the last 5 years.
This is making me really nostalgic because I submitted the application in 2019 and entered here.
Right?
Yeah.
We're still doing it. It worked.
That's
And I'm ready. And then medication assisted treatment. This is just more like an FYI informational slide about the different types of medication assisted treatment that are offered. So buprenorphine is a synthetic opioid drug used to treat both pain and opioid use. It's a partial agonist which binds to opioid receptors. Naloxone or Narcan is an opioid agonist which quickly reverses an overdose. Suboxone is a combination of naloxone and buprenorphine used to treat opioid use disorders. Naltrexone or Vivitrol is a synthetic drug that blocks opioid receptors and can be used to treat both opioid use and alcohol use disorders. I'm pretty sure that one can be a long-acting injectable or taken orally. And we collaborate with an on-site pharmacy, Genoa Pharmacy, to provide medication-assisted treatment. About 45% of our clients, that's not updated. So 49% of our clients. And clients receive medication-assisted treatment for opioid, nicotine, and alcohol use. Yeah.
For folks getting the medication assistant treatment, is there a specific protocol in terms of how much people need to be doing that exclusively on site as opposed to being given different quantities of things to take and use at home?
I think without consulting our medical staff, I would say it's very based on the client and their risk level. That some of the overdoses for the incident review committee are on prescription medications, whether or not they're prescribed to the client or whether or not they get them from elsewhere. So I think that the medical staff are careful about how much they prescribe at a time depending on the client's risk level.
And is there typically standing urine screens for folks on who are doing that?
Yes, we do those here. I don't know the details.
generally, naltrexone is typically what's offered first for alcohol use disorder. That's the pill form. And if someone finds that they're struggling to be consistent taking
I'm
it.
thinking more about like the Suboxone.
Okay, gotcha.
I know our nurses get a little squeamish about the Vivitrol injection because it causes fibrosis. I think the injection isn't done correctly. There you go. There's our brochure that we made. So this goes out with the naloxone kit, the fentanyl, and the xylazine test strips. So there's a preferred education component to the naloxone kit distribution, but then that can also be an impediment if we're trying to like give them out to everyone, but then you also have to talk to a staff to be trained and you just want a kit. So we found a middle ground of providing a brochure that has contact information and a warm line for people who can call when they're using. So they can get more training if they want it, but also they can also just take one with brochure.
We also give out a number of kits to other organizations along with the brochure.
So Genoa Pharmacy is located downstairs. I think they are a great improvement for our organization. They specialize in the SMI population. They offer multilingual services and resources. They offer specialty pill packing for clients. They help negotiate prior authorizations, which is huge. They offer refreshments for clients and collaborate to provide medication assisted treatment. So some of those MAT drugs you need to have them sort of on site. And so that was an obstacle for us before we had the pharmacy. So coordination of care, we've done a lot, so we integrated. And then there has been some work to help make sure that we reduce the burden on the client when they come here if they're eligible for multiple whole health services. So they don't ideally have to talk to 20 people and get lost in our own internal bureaucracy. And so I think there's been a lot of effort and a lot of progress on our coordination of care internally. We've added peer specialists for both the pros and the clinic. At Brown Road, we have community health workers. So the distinction there is peer specialists have lived experience and community health workers don't necessarily have that. They help with the navigation piece and can provide rides for people also to help coordinate their care. We have an interdepartmental referral process and also a committee. So we have an internal electronic form that we send across programs if someone is eligible for a mom service who goes to the clinic or vice versa. And then we have a quarterly committee who looks at those referrals and talks about how did this process go and did this person fall through the cracks or did they get linked to things and how was their experience. So something that I think that committee has identified is there's a statistic about how 5% of clients are responsible for about 80% of medical care utilization. And so the people that we are trying to coordinate care for are that 5%. And so I think we're now asking ourselves, how do we create processes that really wrap around that 5% when they're in crisis to help them overcome those obstacles, like sort of in a simultaneous effort that doesn't overwhelm them.
I just add, since your slide, we also have the court navigator position now. Office of Mental Health funded fully the creation court navigator position for each county. At least one, and larger counties have received more. So we do have somebody in that role, and that is for criminal court specifically, to have somebody right at court when court is in session and have office hours here. We added another 5 hours to their time to do intake and to do some clinical work with clients. So you had an option of using a peer or a caseworker or creating a clinician position. We created a clinician position so they could do intakes right at court to stop that initial step that seems to be really daunting for people. And then they can also do some sessions over here and have some clinic hours here to help people with that full process of getting emergency services. But they are short-term navigational kind of a role, but they can navigate people into this a space and be there for them. So I think we'll look at more ways to coordinate in the future. We're also going to be starting to do some groups at probation. So we're really trying to figure out how better to provide the supports that people need when they're reentering the community from jail or they're on probation, and obviously the care clinicians and the jail reentry workers. So this, like, how do we really expand that whole system of care for people who also use a lot of services, but not necessarily are provided in a way that's effective right now, to make that better.
Quick question, are the community health workers yet able to transport youth in car seats?
I don't know. I'll find out for you.
Thank you.
There are there's like a picture that's specific to maternal health.
Up until the last time I checked, maybe a year ago, the pitch workers were not able to transport infants or other car seat.
I'll find out. For the last year or so, we've had a motors. So motors are like the OMH regulations that apply to the clinic. So we've had a motors project where we've literally gone through every standard of care from OMH And we've talked with our clinic director, support staff, and the supervisors at the same time about how are we accomplishing the standard of care as an organization, and making sure everyone is on the same page. And then having an action plan to update that with our policies and our trainings, to try to align everything in the organization and make sure everyone's on the same page. So that sounds boring, but I think it's really tied up a lot of loose ends, and it's helped us also to reflect that in our forms and our electronic health record, and just add little questions like, if you're supposed to be coordinating care with the parent during the safety plan, like adding a control in the safety plan that says, did you collaborate with the parent, and if not, why? So we have finished going through all of the standards of care. And so I think that's really helped to align things across our organization and make things more efficient. And then just this year, we updated the pros and clinic collaboration of care policy. This one was directly out of the incident review committee. So sometimes clients are shared by the clinic and pros, and one clinician will learn about an incident and the other clinician will not know about it, or will have a different story. And so Hillary and Heather worked together to create a policy about how pros and the clinic work together, especially for high-risk clients. Am I taking too long? I can speed up if
We're doing okay.
you're doing okay. Okay. So coordination of care external, Harmony beat me to it, which is great.
Sorry.
No, it's great. So we offer services offsite, maybe at the Village of Ithaca, I'll find out, South Side, and hopefully GIAC in the future. And then we also offer groups at the SRO, West End Heights, and Titus Towers. We work with the hospital to improve hospital discharge process, both for emergency department and behavioral science unit admissions. I think that will be probably in this presentation forever, but we're always working on it. We have collaborated a lot with the local courts in a myriad of ways, including adding the court navigator position. That we collaborate with Lakeview Housing about shared clients. I volunteered to be the liaison this year. So I sit in on both the SPO committee, and then also they have a second meeting where they talk about shared clients who are already in housing. And we try to just share information back and forth. I've seen that be really beneficial in time-sensitive situations. For example, if a client is at the top of the list for housing, but they can't contact them, we had one person, they couldn't contact them because they're in a state facility. So it helps to sort of to help to connect those dots when it's the timing's pretty critical. And then we have the care team, a response model with local law enforcement. So this is the post-hospital discharge. So some of the things that we've done to try to improve that continuity of care when someone's discharged from the hospital, and then hopefully we can engage them in outpatient services right away. So we have a point person for tracking to the discharge summary from the hospital. We also got access, the hospital offered us this Epic Care link since they transitioned to Epic. So now our medical staff and nurses have a login so they can see the back end in real time. And that has been a huge improvement and a huge help. One of our psychiatric nurse practitioners attends a weekly hospital treatment team meeting. That we coordinate long-acting injectable medication. So sometimes they'll have the first round at the hospital and they need a booster here within a close time frame. So we coordinate with them to provide that. And then there's a statewide initiative with OMH and DOH to improve coordination between hospitals and community service providers. So there's statewide guidance to try to help improve that as well. Collaboration with local courts. So we hired the new court navigator position, which Harmony mentioned. We provide weekly court reports to the 6 local courts. So we have 126 shared clients in 2025, and we provided 1,589 court reports, which is no small feat. We have one person that does it. It takes her a couple hours a week. All of the forensic clinicians have to update their report, and then she collates them and provides it to the court litigators. So that helps us maintain good relationships with clients, and that's just particularly relevant for the incident review committee because we've had an increase in crime in the community, and we've had a few incidents where our clients were both the victim and also the perpetrator. So having those relationships and sharing information is important. So the care team is a co-response model that has been around for 3 years. We're in our third year. So we have 2 therapists who are with the county sheriff's department and one with the police department, and I think we're looking to add another one soon.
Yeah, very close.
Great. So the purpose of the care team is to divert individuals in crisis from the criminal justice system, to avoid unnecessary hospitalization whenever possible, to de-escalate crisis situations, to link people in need, community treatment and support services, provide in-person follow-up support within the first 24 to 48 hours. In 2025, we became a designated OMH mobile crisis team, which basically means that we can bill under a crisis designation.
Some questions.
I just wanted to ask and just make sure that I understand, this is only available during business hours, is that correct?
So when it's not within the care team hours, we have a mobile crisis team. So we have 24/7 crisis services, but it's not always that coordinated co-response model. If an MCT team member responds like in the middle of the night, they can call law enforcement for backup if they need it.
And the officers can put together like a safety plan, so they go respond and work with somebody, and it's not at a level that they need to go to the hospital.
Right.
But they could put a plan in place together with family, friends, and have a follow-up in the morning when care staff is available.
And weekends too, this same system.
We have somebody on call 24/7, a team of 2. During the hours so that the care teams are not activated. So that would be weekends and holidays and after hours. And the county's care team right now goes to 8 o'clock at night on weekdays.
Not the city.
Not yet, because we're getting a new position. And once we do that, we'll have them be consistent hours.
Thank you.
Is the mobile, I'm used to, the last mobile crisis team I had was in Rochester, where providers could proactively reach out for them to do like warm check-ins with folks and like coordinate ahead of time. Is that a thing that exists?
They do wellness visits. Is that the question?
Yeah,
The
and
care
like,
team does a lot of engagement and outreach with people. Besides just responding to immediate crises.
is the primary way of getting a hold of the mobile crisis team through 988?
No, it's through 911.
They also, so they do follow up. It's like part of their note as whether or not its follow-up is required. And so they collaborate with MCT to provide follow-up services when indicated.
Can the MCT team come to one of our meetings?
Well, so do you want the care team to come to one of your meetings or somebody on mobile crisis team?
Mobile crisis team. I mean, I also have
Crisis
people
team
from
is
the
on
county.
call. They're clinicians
Uh-huh.
and other staff. Corinne is on the mobile crisis team and she works a lot of shifts. So there's a primary and a secondary position on the mobile crisis team. And so there are staff who are working, who choose to be on the team. They get additional training, they have a meeting, and then they're available for on-call calls, but they wouldn't do an on-call call as like an engagement effort or something like that, because it's after hours. It's, it's evenings and it's weekends and it's holidays. The care team would be more like what you're asking about, somebody who goes in and checks on somebody to see how they're doing before a big crisis kind of situation or follow-up after a crisis.
Our Kristen actually is on mobile crisis as well, so there's some overlap.
Yeah, sometimes people work the mobile crisis hours in addition to the care hours. Although one might think for their own health, they should not do it too.
Right.
Anecdotally, and I don't have a reason for this, but when we started the care team, the MCT services offered after hours dropped dramatically. Like we were getting lots of calls in the middle of the night and on the weekend, and the clinicians were getting very burned out because they were also working as therapists by day. And then when we had the care team, it seems that a lot of the crises are mitigated during the day, and then there's less of a need at night.
But this says it just started in 2025.
No, we
No,
became a designated,
Designated.
we got our license to bill for crisis services.
We had already had a mobile crisis team,
Mhm.
but it wasn't designated through OMH because it was funded through a different funding source
I
years
see.
ago.
I see.
And then the Office of Mental Health really wanted to make sure every mobile crisis team in New York State was designated by them, which was an enormous amount of work.
So
And
they
they
are-
did on policies and procedures and putting a whole application together.
It's mostly there because I had to write all the policies and procedures and I wanted someone to know.
Is there an effort to have the care teams and mobile crisis team in collaboration with like our new home-based crisis intervention services? Because when I recently talked with a county care team member, she was unaware of the youth home-based crisis intervention service, which I found.
Is that something that Northeast Pediatrics is doing?
No. This is,
You say we.
so Racker has a home-based crisis intervention team, as does Children's Home of Wyoming Conference.
I know that we have to apply separately for a children's crisis.
No, this is a different thing. It's like Children's Act. They created 2 home-based crisis intervention teams, so we should just have them come to one of our mobile crisis team and care team meetings. We have them every Friday. We'll just invite them.
That would be great because
I'm surprised they don't know that already.
the
but-
cross collaboration has not been optimal.
So I was just wondering, the mobile crisis team can intervene for a child, correct? Yes? Or are you saying that that's?
Yes,
Yes.
and also we're trying to get a special designation, which largely has to do with a different billing structure.
Our team does respond to children's issues. To make it a designation under OMH designation, they are requiring that we put our entire application that we already submitted to them through a different portal. So we reached out, we haven't got into the portal. And then all of the information that they want so that they can do the final stamp of approval. So once Janet finds the magic way to get into the portal and submit all of the things they told us they wanted, we should be officially designated, but we are not serving children while we wait to get access to the portal.
Which also brings us to the next set of slides, I believe. Oh no. So this is the Sheriff's Department dashboard. So I put the link in here. Also, if you just Google it, you can find it. If you see at the top, it says demographics, responses, and outcomes. So I recommend visiting it. It has filters if you want to see like a certain date range. The responses and outcomes I think are particularly interesting because you can see the types of situations and also the outcome of a situation, like how many people were transported to the hospital or how many people were de-escalated before that was necessary, or days of the week, which that data was really interesting when we were looking at like crisis calls and when they happen. So this is a data source. It's our people, but not our data, but it's really great and it's a community resource and I just wanted to highlight it. So school-based services, these slides are all new for people who were here last year. That we have had more youth incidents in this past year, and the acuity of them has been more severe. And so we are also participating in, OMH has these quality improvement collaboratives, like I mentioned, the OUD one. So this year they had a school-based satellite one. So we are participating in that. I'm jumping around on the slide to the bottom, but the OMH quality improvement project is focusing on technical assistance with billing because there's an enhanced rate when you offer services at the school. So we're expanding services and hours to new and existing satellite locations and a focus on integration with school staff and infrastructure. So to address the question about crisis with youth, a lot of that happens with our school-based services and a lot of it happens in collaboration with school social workers. And some of that happens after hours too. So there's a pretty tight network of notification between like school social workers and school staff and the school therapists that happens outside of FCT. So currently we have 14 school satellites throughout Tompkins County. We recently added Caroline Elementary into Middle School, and we're working, we're in like the planning phase with BJM Elementary School. We're providing services at Southside's after-school program, and we're working with GIAC to hopefully offer services in 2026. We added 2 new school-based therapy positions and a peer specialist position. So we are growing those services as they grow, as the need is also increasing. This is a breakdown of some data just about the number of youth served in each of the schools. I apologize that because of like the way satellites are licensed, that some of them are broken out into middle and high school, and some of them are just middle school or just high school. So overall, we had in 2025, we had 543 youth served in schools. So, and then on the left-hand side is like an overview based on month. So these numbers are February of this year, but we offer about 165 hours of services per month. We had 26 new referrals. We enrolled 12 new students. We offered 330 services that 49% of our children and youth recipients are on Medicaid. 9 of them are uninsured. And we have an active census of 232 kids.
9 kids?
Are uninsured.
Okay, not 9%. Okay.
Yeah. Yeah, it's only about 4%.
So typically, how long do students receive the services?
I think I'm going to guess, and also based on like the numbers without consulting anyone and without the data in front of me, that they are going to receive services throughout the school year. And then there's like some students receive services at the clinic during the summer, and some will graduate or maybe close their episode of care. And then there's an influx of new students.
Are clinicians offering any groups?
At schools?
I don't know.
Yes. Yes. So person-centered services, I created one bucket for several things, including documentation, identifying risk, and tailoring our services to be more specific for the needs of the client in front of you. So we have a level of care policy, which was recently updated. So now it has 4 categories of our levels of care, which coincide with different frequency of treatment and types of services. So there's psychotherapy treatment, psychotherapy with medication management, supportive counseling. The distinction there is somebody who doesn't, maybe they have been in therapy for a long time and they're not necessarily actively in like working on therapy goals, but they still are receiving medication and are receiving therapy periodically to support that. And then we have some medication treatment only clients. They are our longest length of stay clients. Some of them are a decade here, where they're just getting medications that are too complicated to be prescribed by their primary care physician. They see a nurse every 6 months to check on their physical health and to check in with them. I will also say our nurses are phenomenal. They they provide a lot of counseling. They go to people's homes. So they are still looked after by a clinician, but they're not there.
They're not in therapy because they choose not to be in therapy, or?
I think some people are maybe too disorganized. So if some psychotic clients are on a long-acting injectable medication and they really need to be on that medication, they're not an appropriate therapy client. They would be a medication only client. And also some people I think are stable. And so they maybe don't need to be in therapy, but they do really need, they're stable because they're getting that medication that they need. We offer offsite intakes and services in collaboration with other whole health programs, including the MOMS program, the care team, at School by Satellites, and we have weekly therapeutic groups at Tice Towers and Lakeview Housing. Like I just said, our nurses provide home visits when necessary for long-acting injectable medications and blood draws. And clients attend in-person annual appointments. So this has been a huge improvement for the documentation. So they come in person and they update their treatment plan, their risk assessments. They see a nurse for their health assessment. And we try to coordinate those with their psychiatry appointment at the same time. So when the increase in the number of people who've been screened for substance use to 75% is largely because we're asking those clients who have been here for 10 years, who do a lot of telehealth, you have to come in once a year to like update your stuff. So this is a similar graph to last year, but it continues to improve. So something that really helps to keep clients engaged is to get them right when they come here, when they need somebody, and to make sure that they are seen quickly. So this number has improved dramatically through time. So this represents the number of days from the point when the client wants services or expresses interest in services, their first intake, their second intake, and then their first therapy appointment. So it's representing 3 services, not just like day 1 to day 2. And we don't currently have a wait list. I think go back one. I'm wrong, sorry. High-risk clients. So here are some of the things that we're doing for our high-risk clients specifically. We have, I think, about 80 people on our high-risk list. So we have a weekly treatment team meeting, which is all of the clinicians and all of the medical staff, and they highlight concerns that need to be addressed immediately and look for feedback from their peers about how to address them, and also talk to the doctors to consult with them. And Hillary just initiated high-risk pod meetings. So that is bi-weekly, and it's just with one medical provider at a time with people on their caseload and the clinicians that are assigned to those high-risk clients. So they can have like a more intimate, in-depth conversation about how to address those high-risk clients. I think that's very closely related to the IRC because those are the same clients that have reportable incidents. We do utilization reviews specifically for anyone on the high-risk list or anybody who has a reportable incident. So that means that our utilization specialist who we're hiring for, if you know of anyone, that they look just at those charts and they look in depth to make sure that they have all the risk assessments, to see the content of the last date of service, if collateral information is there, and if it ties into the care that we're receiving. That we provide monthly caseload data and to all of the clinicians, so they get to see their caseload, how often they're seen, the last date of service, whether or not they have a CSSRS, whether or not they have a safety plan, whether or not they have the risk assessments.
The CSSRS is a suicide risk screen.
And then the weekly, they get that for their entire caseload every month. They get that weekly for their clients that are on the risk list. So, and they get the day before the risk meeting so that they can kind of look at their people and talk about them in the meeting. We updated our violence risk assessment and trained clinicians, and we implemented the annual appointments where it's an opportunity to update those risk assessments.
Another thing we do is we track how many high-risk clients any clinician has.
Is there a ballpark figure for that and for monthly caseloads overall?
There's about 80 people, or 80 to 90 people on a clinician's caseload. The nurses, I want to say like 100 to 120. And it depends on the clinician, but I'd say about 5 people, like about 5 of those are high risk.
Right.
Perfect.
And the standard for caseload would be around 80 to 85. So we're right in the ballpark of where we want to be. That's right.
That's also improved.
You're probably the only clinic in New York State that can say these things.
All right. All right, so this is just some data on our annual appointments. So you can see the show rate and the number of people that attended per month. So this is a work in progress. We are not super strict that they have to come, but we just try to call and get people to come. So that's where we're at with it right now. Staff recruitment and retention. So we have the HRSA loan repayment program, which has been really successful in helping to retain staff. Clinicians can get up to $55,000 back, and our nurse practitioners can get $80,000 back for a 2 to 3 year commitment. After they finish that commitment, if they have outstanding debt, they can reapply for an extension. And then Harmony worked really hard to expand the licensed clinician therapist credentials. So it went from just an LMSW to now different types of therapy credentialing, which I think has helped to improve the diversity of our staff. And then the county has the hiring for emergency limited placement or the HELP program, which waives the civil service test requirement. And is a surprisingly huge obstacle, and I think particularly cumbersome for someone who has a license and had to do a test already, that they have to do another test. And they've extended it now to administrative positions. So that's wonderful. And we added at least 2 new school therapy positions and a peer specialist position. So staff wellness and growth, I stole this from Hillary's meeting minutes because she's in Costa Rica. But so things she's working on for staff wellness is quarterly no client days and a 2-week cycle for catch-up days with paperwork, more flexibility with comp time and unpaid time, 15-minute breaks after sessions and a longer lunch. Debriefing time built in today. I know that was an important one for staff to like have an opportunity to reflect on some of their cases. All staff training days, we just had one. And we developed a training policy which creates intentional and equitable opportunities for professional development outside of those group opportunities. So if staff want to do a conference or do something more individualized for their professional growth, that there's some structure to do that. And these are the policies. So I will go super fast. We're working on our medical services policies. One of our nurse practitioners took initiative, and she is a rock star, and she's been updating all the medical service policies and working with our clinic director. The intent and engagement policy, there's been a lot of changes to that. The most recent one, we just added the annual appointment protocol. The high risk policy, the most recent change was distinguishing between monitoring and high risk status and creating those treatment team pods for the high risk clients with their medical staff. The level of care policy was updated to have those 4 categories. The offsite policy just established protocols and safety for offsite services for pros and the clinic. The court navigator policy outlined expectations and guidelines for the new court navigator position. The clinic and pros coordination of care created a framework for collaboration between clinicians so they know what to expect and they can kind of like have some checkboxes of things they need to do. That we did that crisis intervention services policy procedure manual and were granted our crisis services designation. That we have the training policy that I just discussed, and then I think we're working on an AOT policy like tomorrow. And that is it.
Oh, great.
Very nice. Done a lot. Something that I wanted to mention is I sit on this committee, sometimes the IRT committee, and the tone of it is so constructive and positive and supportive to the clinicians. And it seems like without exception, people bring up hard things and people listen, and it's a nice constructive meeting. So.
It's hard at 8:30 in the morning, but
I also want to note that, well, I say thank, but more importantly, a lot of respect for the work that the department, the 2 departments in the merger have done and gone through, you know, having lived through and participated in the not always, concerns, a lot of concerns that people were expressing about whether this could happen and whether it could really create a new entity that was larger than the sum of the parts kind of thing. And it just warms my heart that the work that's been done and clearly a really living of the vision that we had when we, you know, put things forward and tried to create something new. So thank you to everybody that's been doing that.
I have a question. I've sat through a bunch of these over the years, and it suddenly occurred to me tonight, I don't know if any other OMH programs have to provide the information that we do. I was wondering, does Family and Children's supply a similar document to OMH?
They have their own board, and so they would do this with their board. Yeah.
Right. And it occurs to me, I'm glad to hear that their own board goes to it. I also wonder because our mandate is much larger than to just be the board for the department, whether it would be useful to um have information about their incidents, since that would give us a larger view of what's happening in the community, especially to people who are perceived to be seriously mentally ill. So just something to think about, because we're not just the the board of directors for the clinic or for any of the department's programs. This board has a much wider level of responsibility.
Right.
But I'm glad to hear that that their board would, that Family and Children's Board would look at their incident review. So that's good to know.
OMH also might be a resource for that because we have to report everything in their NIMERS portal. And so I'm assuming that all the other organizations that are required to report use the same data system. And so I can ask OMH if they can provide a report of like the count and type of incidents in a year for our county.
For the county.
Yeah.
It would be, I think it would be useful just for us to have a wider sense of what's actually happening in the community.
It would give you more of that trend data around suicides and particular incidents.
Right.
Sure, it's true. And the total number of people really being served.
Yeah. Any other questions?
Without of course, appearing as if we're stepping on somebody's toes or somebody's, range of responsibilities.
I mean, I spent hours of my life putting data in. I would love to ask for them to provide something out.
I believe you said that it was an unprecedented number of incidents. I wish I wasn't hearing that word so often these days. I know this is just speculation, but is there anything that indicates why? I mean, I can have a million guesses.
So part of it is that thing about speeding tickets, about like if you have more cops on the road, that you have more speeding tickets. So we started, I think it was underrepresented that we needed to report crimes in the community. So then there was some clinician education on that and some leadership on that. So I think two handfuls of the cases were crimes in the community. So that's part of it. But there were also more deaths. There were also more suicide attempts. And I don't have necessarily anecdotal reasons for that. There is an increase in youth incidents. And I know that the clinicians are like trying to provide their support at schools, not just for the kids that with the incidents, but for their entire like school community, because the entire school community is really impacted by those incidents.
We saw a record number of incidents in like every category at Cornell last year too. So
We did a lot of training for our clinicians this last year, and it's called CAMS training to really strengthen our ability to support people clinically who have suicidal ideation, and that should be a treatment goal in and of itself. So I think we're trying to find some ways to better support people and give our staff the tools to do that work. So they've done a lot of other trainings besides that on suicide prevention. And then one of the things I learned from VOCES when they had their audit from OMH this year is that OMH was very focused on treating co-occurring disorders with youth. So, and we just know that kids with substance use disorders often have a significant mental illness, and it may not fully have presented itself yet. So you're seeing the substance use before you're seeing the severity of the mental illness, but it's coming. So I was really happy to hear that because they reached out and said, give us some support so that we can better, like, who should we reach out to in the community that can help us better address that? And I think that's an area that we're going to continue to need to focus on and strengthening is around treating co-occurring disorders among kids. We talked a lot about medication assisted treatment, but our clinicians have also gotten a lot more training in how to bring together both substance use in the therapy session along with mental illness that people are, and it's impossible to not treat both together. And yet for years, that's been the standard. And yet today, that is how people are still trained in school to teach, to have them be completely separate issues. Until we get our schools to fix this, so that clinicians come out just knowing to do that is, gonna continue to be a huge problem. We have hired a number of CASACs, we have clinicians who are getting their CASACs. So, I think we're getting better at the substance use piece. It's still gonna take a lot of time, and we gotta figure out how to make a better, warmer handoff for kids who need substance use treatment, exclusively at this point. That's an area we're still kind of weak in.
In relationship to current events, I know that one of our therapists expressed concern that we contract with the language line and that the language line interpreters, especially with kids, are having like vicarious trauma because they're interpreting for like these really intense immigration stories with kids, and that afterwards the therapist stays on the line with the language line person who's like in tears. So I think that speaks to like the impact of current events on mental health of the people and especially the kids that we're serving.
Well, thank you so much, Janet. This was great. Yeah.
Sorry if it was too long this time.
I love what Jen says, it's not gonna be as detailed as normal. This is not detailed, but
Right. I forgot.
no, it was terrific.
It'll be good. We know it'll be good no matter what.
Before we adjourn, I just want to remind those of you who haven't done the sexual harassment training yet, please do that. I think we only have about 6 of us who have done that, and do it as soon as possible. I know we would appreciate that.
We're out of compliance right now. So
I want to know
Yes, in
where we
compliance.
turn in our answers, because it says that you should write them
Oh,
down
my.
to all the little scenarios
Uh-huh.
and the question, the interactive parts, and says that you're supposed to turn that in.
To me.
Well, I'm not gonna do it. I mean,
That's responsible for them now.
but it's not the attestation. I mean, it was literally saying you were supposed to write down your answers and
Oh.
give it to HR or something in your.
It was a generic, like the city used the same one.
Yeah. Yeah,
They just did
people
the
actually
attestation.
coming in with their answers to show that they got it right.
Just they mixed it up a little. They had like the same one for a few years and I think they switched it. And I was like, oh, that's nice.
Yeah, no, it was new this year.
Yeah, it was.
Yeah, and better. It gets better all the time. I've always been impressed by the job that they do with that.
The HSC offers a free one to the community every year. So if you see that on the listserv, it's a great opportunity. Yes.
Good. All right. Well, with that, I think we're done. Do we need a motion to adjourn first?
Is this your first meeting?
Yes.
Good first meeting.
I think we're adjourned.